My goal with this video is simple. I want you to pass your National Registry Paramedic exam. I want you to come back to this video and say, Evan, I passed. Yes, I'm a paramedic. Let's go. That's what I want from this video right here for you. Now, this video, I'm going over every single category of the National Registry Paramedic exam, and there are 6. This video is going to come with a free study guide, free prax questions, and stay to the end. I got a little bonus for you to announce. Now, let's get stuck in. Let's get started. And we're going to start with Airway. Now, the number one spot I see paramedics mess up on NREMT is capnography and acid base. I know this because I get so many messages from students struggling with this. We're tackling it right now. Now, let's start with key terms, and we're going to work our way up. End-tidal CO2. This is described as, remember folks, this is exhaled carbon dioxide, okay? And we're getting a measurement. We're going to get a waveform, and we can read that waveform, okay? And we're also going to get a number. Based on that end-tidal number that we get, we see much more. We do see the ventilation of the patient, yes, but we can also see the perfusion status of the patient as well, and forget that. We're going to talk about it. Now let's go over these. It is the measure of the concentration of CO2 at the end of exhalation. We get a number, okay? We get a number. What is that? Right here, okay? This device that provides a digital numeric reading of the end-tidal CO2. Then our graph, okay? We say capnography. Capnography provides a number, yes, and a visual graph. And as paramedics, we understand how to read that graph. And for NREMT, we got to understand capnography. And if I give you a strip, if I talk about, is the end-tidal high, low, is it acidosis, alkalosis, we got to know that cold. Well, we're going to know that right now. So hang with me, okay? So this is so important. Where do we see end-tidal? Well, we're going to go over a lot, but the first few things I like to think about is, well, do we use it at cardiac arrest? Yes. Do we use it for respiratory patients? Yes. But I talked about acidosis. Okay. Alkalosis. Well, DKA. Diabetic ketoacidosis. Maybe I could use it there. Okay. So get that brain moving here, right? End-tidal CO2 is a great supplemental tool, okay, that we're going to use. Now, the normal range of end-tidal CO2, you got to know this cold, folks, 35 to 45. That is your normal end-tidal CO2. Me and you right now are end-tidal. It's probably 35 to 45, okay? It's a use. These are the uses. What are the main uses? Why we use capnography, okay? And I want you to start thinking in your head as I'm going through this of patients you've seen, case scenarios. Think about it, okay? And try to, man, could I have used capnography in that case? Because this is what NREMT wants you to start thinking about, okay? Now, first, okay, we think about end-tidal. We talk about cardiac arrest, okay? We can see the quality of our CPR based on the end-tidal CO2 number that we're getting. How's our capnography waveform? We want to get that above 10. We don't want to be below 10. That means we got bad CPR. We want to be above 10. That's our magic number. Okay, now, we also going to use end-tidal to confirm placement of advanced airways. But remember, folks, I can put end-tidal CO2 on anybody and anything. What this means. If the patient, there's no airway, I can do nasal capnography. I think about this in an asthma patient, COPD patient, even a cardiac patient. It's a supplemental vital sign, okay? Now, also, when we talk about airways, I could put end-tidal on a BVM. I could put end-tidal on a supraglottic airway. I could put end-tidal, I must put end-tidal on endotracheal intubation, RSI, etc., etc., etc. Okay? It confirms the placement of your ET tube. It is a must. I'm telling you, you can also use N-Tidal, also can use it in other cases, like to assess ventilation status. Are they hypoventilating or are they hyperventilating? This is important, okay? You're going to get all this down, so hang with me, okay? Now, I have some little pearls here, okay? Remember, we want to avoid accidental hyperventilation in patients with head injuries, okay? We talked about determining changes in cardiac output, okay? We talked about that. And also providing the first indication of ROSC after cardiac arrest. So again, your alarm bells start going off. Okay, I got N-Tidal. Okay, cardiac arrest. Okay, respiratory, airways. Okay, right? See, some of the main pathways we're going to use N-Tidal. Start thinking about these things, right? Okay. Now the big one here, people mess up, hypo and hyper, acid base. Hang with me. We're going over all that good stuff. Okay. First, we got to get down and understand this. Now, capnography, again, a quick overview for those folks that really struggle, is a visual display of the rate, what is the depth, and the effectiveness of ventilations. So remember, N-Tidal can show us perfusion, it can show us ventilations, okay? And it's got something to do, we're going to talk about acid base later on, okay? Now, this provides an estimate of the carbon dioxide production, the alveolar ventilation, and the arterial carbon dioxide production, okay? Remember that. We'll talk about more in a minute. Okay, now, capnography. It indirectly measures perfusion, okay? Too many paramedics just think that N-Tidal is simply for respiratory patients, but it's much more than that. Remember that, this is key. Remember that our pulse oximetry is not going to give us instant feedback. N-Tidal will give us pretty much instant feedback on the status of our patient as far as their status, okay? Or a pulse oximetry may take a little while. Now, folks, I got a lot of pearls here, so I'm going to read these out, okay? Just listen to me here on this segment. Carbon dioxide is a byproduct of metabolism. And by the way, I'm going to do a quick pause here. Folks, if you have any questions while I'm going through any of this, drop in the comments. I try to answer all of your questions. So if you have any questions about anything, please drop in the comments. I got your back. Again, Evan, the paramedic coach. Well, let's come back. Now, it's important for CPR. If N-Tidal CO2 is going to decline, it indicates chest compressions are not fast or deep enough. So we're at a code. N-Tidal's under 10. That's bad news. I want to say N-Tidal minimum above 10. I get ROSC. It shoots up like this. Okay, literally almost like a giant, literally almost like a giant triangle spike. It spikes up. That's ROSC, return of spontaneous circulation that I get back, meaning I got a pulse again. I'm not in a cardiac arrest at the patient. Okay, so this is the big key. When you're with your EMTs, you want to tell them, you see that number right there? We've got an airway established. That's our N-Tidal. That number is going to tell us how well your compressions are doing. Keep that number above 10. Keeps them motivated. Now, it provides information on bronchoconstriction. Folks, we're going to talk about it, but a little preview. Shark fin, okay? If you don't know this going into the exam, you're not going to pass. Okay, we got to understand the N-Tidal waveform. These are easy questions. We got to get this down. Now, if I see that shark fin appearance on N-Tidal, that means what? That means I got bronchoconstriction. What does that mean? I got tight airways, meaning I probably got one of the three culprits, anaphylaxis or asthma or COPD. Bronchoconstriction, I got tight airways. Right. Now on that point, if the terminal bronchioles are constricted, there is uneven emptying of air from the constricted airways. It represents as a shark fin waveform. I got a beautiful slide coming up. I'm going to show you all the different waveforms. You're going to know all of them. Let's go. Okay, right here on YouTube. Now, ROSC. It displays a sudden increase in CO2 levels. Remember, it's the spike in the end tidal. Oh, I'm in a code and I spiked my end tidal. It's ROSC. They got a pulse back. It's typically the first indication that they got a pulse back. ROSC, return of spontaneous circulation. Don't miss that question up. Was achieved. Okay? Cool? All right, we got a good groundwork now. Now we're going to pump it up a little bit and let's get into the real meat and potatoes here, okay? Capnography can be used in patients who are and are not intubated. For example, intubated patients, we use an end-tidal CO2 adapter placed between the advanced airway and the ventilation device connected to the cardiac monitor, okay? For example, okay? Now, could be the ET tube, supraglottic, BVM. We talked about that. What about the non-intubated patient? Again, that asthma, COPD, cardiac patient. We put a nasal cannula on the patient, okay? It's performed to see the ventilatory status and the effectiveness of our treatments, okay? And it is a way to continuously monitor our patients. Can I share something with you here that's not shared here? What about a psychiatric patient? Okay? Give you an example. You go to a patient, let's say they're a violent patient, let's say they're psychiatric or mental health, or let's say it was drugs. For whatever reason, we have to chemically restrain this patient. For whatever reason, okay? Let's say we do that. Well, now you've just sedated the patient. Wouldn't it be nice to monitor their ventilations? So one of the best things you can do if you have to sedate somebody for that reason, 1, get vitals. You probably didn't get them earlier. 2, get a blood sugar. But 3, I like to take nasal cannula, and now I can see the ventilation status after sedation. Pretty cool? Okay, I love it. Let's continue. Great work so far. Now, just some pearls here, folks, to remember your indications. I have listed these out for you here, okay? You can see them all here. Again, for the intubated patient and the non-intubated patient, okay? Now, we've gone over these, but I want to have a nice chart for you here. You want to screenshot this? Go for it, okay? It's all here. Remember, it's all going to be in your study guide, okay? You're going to see here that link in the description, okay? Down below, link in the description, free study guide, free quiz, and everything that we're going over today. It's yours, my gift to you, just for hanging out with me here, okay? Let's do this. So, this is the normal capnography waveform, the slide everyone's been waiting for, okay? So, as we can see here, this is what normal looks like. Now, just look here. Does this look like a shark fin? No, it does not, okay? Does this look like it's sloping down in any way? Does it look like it's trailing off? You'll see examples later on. No, it looks pretty much like a slightly upright square, okay? That's what you want to see, okay? A little tip point right there at D, okay? So we have here a little inspiration, the expiration phase, inspiration. Folks, think about this. We're measuring exhaled carbon dioxide. Well, when does carbon dioxide come up more? When will we get a number on that? Well, oxygen goes in the body and carbon dioxide goes out. So if I exhale, that's my carbon dioxide. Higher concentration. I breathe in, I want the oxygen. I breathe out, I get rid of the carbon dioxide. So under the actual wave itself, you see this is what it is. The respiratory baseline. The respiratory baseline, okay? So as I exhale, what's going to happen? I'm going to see my end tidal rise till I gain the tip top of my expiration, and I start to inspire and come down. And I go back to baseline, okay? So we can see here, the baseline, I upstroke as I breathe out, okay? The plateau, we get a number based on where we're at, and then I'm gonna breathe in. And baseline. Does that make sense? Okay, that's it. And really, the easiest way to remember this is, folks, we breathe in oxygen, we breathe out carbon dioxide. So of course, I'm getting the number that's going out. And I'm getting the top number of what I'm going to get, and then bam, there's my number on my plateau. There it is. Okay, now, this is important. This you should know, but again, I'm always thinking about these easy questions we can pick up on NREMT to show the exam that we know what we're talking about. So I like to give these little definitions. The height of the waveform is the amount of CO2 exhaled, okay? The length of the waveform is the time of the breath, okay? The baseline is normally 0, and folks, it only detects CO2 from ventilation, okay? Makes sense? This is good to know. Again, we don't want an easy question like, what is the height of the waveform in end tidal, and you get it wrong, okay? There it is. Okay, now, here it is, folks. The Holy Grail, okay? What are we talking about? This is our waveforms, okay? So now they show you a waveform. You have an idea of what might be going on, okay? This is a great image. And again, it's going to be in your study guide. Don't worry, but check this out. Now, the first one here we have is sudden loss of the waveform. Okay, this could be a tube that is disconnected. ET tube could be dislodged. It could be kinked. Okay, and you can see it's, or just they lost, or in a bad case, they've lost their circulatory function, which would be really, really bad. Okay, hopefully it is a ET tube problem and not they just went into cardiac arrest. So we can see here, we're moving along nice, and then it just goes away. So what is that? Check your vitals, check your tube. Okay, decreasing end tidal CO2. I got a good waveform, then I get, see how I was talking about earlier how this changes, right? With how we're going down. Could be a partial obstruction, okay? Again, could be ET tube, again, it got moved around. So basically in this case, check your tube and maybe even consider suctioning your tube, right? Obstruction, that's fair. Check your tube. CPR assessment. Again, our goal with CPR, during CPR, now here's a big question. During CPR, are we going to be 35 to 45? Probably not. Probably not. We might not be. But folks, you got to be above 10. So that's the big sticking point. We got to be above 10. We got to be above 10. Okay? That's our goal. Okay? Right? Now, this is what I'm trying to get at here. Look at ROSC. Does that make sense? Look at ROSC. Look at this. Boom. Shoots up like a rocket. Okay? You see the difference? We're going along at a code, going along at the code, boom, right? Big thing with CPR, they're going to hit you in the exam and in the field, be above 10. That's our key point. Now, bronchospasm. We can see here a bronchospasm. Look at that shark fin appearance. Look at that. Versus we look like, let's say, more normal over here. Okay? That looks like a shark fin, right? Exactly. That is your bronchoconstriction. Hypoventilation, again, this is very important. We'll talk about it as we go on. But just a little preview here. When I hypoventilate, what does that mean? This is the big point. This is the one you want to put notes on. When I hypoventilate, look at my waveform. What did we just learn in that last slide? Were you listening? The height of the waveform and the length of the waveform. How could that clue you into what hypoventilation might be happening in your patient? Which of these two patients is breathing faster? The hypoventilation or the hyperventilation? Who's breathing likely at a faster respiratory rate? Hyperventilation is breathing a lot faster. So the person having an anxiety attack, for example, one of the ways in this case, you can see they're breathing a lot more times, aren't they? Sure. And what happens to hyperventilation? Their end tidal CO2 goes what? It's going to be trending down. Trending down. But look at hypoventilation. What's going to happen with them? It's going to trend more up and it's more slow. Look at those respirations. Look how long this breath is. And look how fast this is. And then finally here, folks, decreased end-tidal CO2. We can just see here apnea or sedation, okay? Does that make sense? Does that make sense? So obviously, folks, with that being said, of course, if we talked about with psychiatrics, but in any case, if we have an airway in place and we're sedating a patient, well, of course, we're going to do end-tidal to confirm a tube. But you want to watch that tube to make sure either if your patient, you sedated them with an airway, they're not waking up, they might need more sedation, etc. Okay? So it's important as a monitoring tool as well. This makes sense? Get any questions? Please drop it down in the comments. I got your back. Since 2020, we have helped over 60,000 students prepare and pass their NREMT exams. Our flagship program can be yours. It's right in the description down below. Lifetime access, 480 plus videos, 2,000 practice questions, worksheets, drug cards. This is how my students get ahead not only in school, but for National Registry exams. Pick up the Video Vault today, right down in the description, and study with me. Let's get after it. Let's go. So now I want to get into acidosis and alkalosis and everything to do with you understanding acid-base. So far we went over capnography. Now we understand capnography and how it works. Now I want to talk about acid-base. So we can just make sure if we see anything in this realm on the exam, we just check it right off because we got it. Okay, acidosis and alkalosis. We start and we float through. The buildup of excess acid in the blood and the body's tissues. Makes sense, okay? The pH is more acidic than normal and the excess CO2 or lack of bicarb is present. Okay, got it. Alkalosis, a buildup of excess base in the blood or body tissues. The pH is less acidic than normal and a lack of CO2 or excess bicarb is present. Okay? Makes sense? Acidosis, buildup of acid. Alkalosis, buildup of base in the blood or body's tissues. Makes sense? That's simple. Okay? Now, let's move forward step by step. Okay, here are the numbers we got to know. The pH, 7.35 to 7.45. That's your pH, your normal pH. Hey, what was capnography? Oh, end-tidal? 35 to 45. Oh, okay. Well, remember this, your PaCO2, which is the partial pressure of CO2 in the arterial blood, happens to match the same number as your end-tidal for a normal realm. So that's easy to remember. CO2, the normal range of both is 35 to 45. Okay, cool. There it is. Okay, now I'm going to circle this right here. CO2 is acidic. Remember that. CO2 is acidic. Okay, I remember that. Bicarb, HCO3. Normal, 22 to 26. Well, I'm going to tell you that bicarbonate, which is HCO3, is basic. Okay. So CO2 is more acidic and bicarb is more basic. Hang with me. Now, let's talk about each one of these so we understand what's going on in the body with each one of these. Make sense? Okay, let's do it. Now, here's how we're never going to forget respiratory acidosis for the rest of our career. I just shared with you that CO2 is an acid, right? Makes you acidic, right? If I say, hey, your patient's in a respiratory acidosis, Usually respiratory? Yeah, okay. Well, if CO2 is an acid, don't you think that respiratory acidosis means that they're retaining or they have too much CO2? They're retaining CO2 because it's an acid? That you'd be right. It's caused by retention of CO2 increasing the acid. It's either an imbalance in the CO2 production or a lack of CO2 elimination through the alveolar ventilation. Now, when I say that term, a lack of CO2 elimination through alveolar ventilation. Wow, doesn't that confuse things? Couldn't I just say I'm having a hard time exhaling, having a hard time getting CO2 out of my body, so I'm hanging on to it for dear life, like in COPD? Well, I just said it. That's how I remember it. It's simple as that. Okay? The other thing here with this patient is there's an increased risk of hypoventilation. Wait a second. Didn't we talk about this earlier? Let's tie it all back. Remember that image that I showed you of hypoventilation? Was the number of the end-tidal CO2 that we saw, was it high or low? It was high. Are alarm bells going off? Are light bulb moments happening? Let's go. Okay? Now, a lower respiratory rate causes an increased retention of CO2 as not exhaling as much or as deeply. Okay? So what we're trying to say here, folks, is if my respiratory rate is lower, I'm at risk of hanging on too much, retaining too much CO2. When you hear this term, they're retaining, oh, they're retaining, oh, they're retaining. They're retaining CO2. They're having a hard time getting the CO2 out. Under normal conditions, again, just think basic. What do? We breathe in oxygen, we get out CO2. If I have an issue like asthma, COPD, or obstructive sleep apnea, and I'm having a hard time breathing, and I have a COPD patient, and I have a hard time exhaling, I retain. Make sense? Now, other causes here that I have, if I have a chest wall injury, I might have a hard time exhaling too. What about neuromuscular impairments causing diaphragm weakness, like a TBI, an airway obstruction, or an opiate overdose, right? And you notice in some of these cases, you can see the overlap, right? Again, some patients have a hard time getting it out. Some people are just breathing too slow, but they all end up here. Make sense? Okay, medications. Look, so if I sedate you, what happens? Your respiratory rate gets really low. Well, if you're not breathing out as much or as deeply, we can get this, right? We all end up here. Is that fair? Okay, beautiful work. Let's continue. Now, on the other side, now we got to think, okay? Respiratory alkalosis. Well, I'm telling you that respiratory is the culprit. If on the other side of respiratory, I shared with you earlier that CO2 is an acid. So if I have too much of the CO2 in the body, what's going to happen? I'm going to get acidosis. I'm going to retain. What's alkalosis? Let's find out. Oh, it's the opposite. It's caused by hyperventilation. There it is. Okay. It's the excess elimination of CO2 decreasing acidity. So what this means, folks, when I say you're retaining CO2, you're breathing too slow, you can't get rid of your CO2, your end-tidal is going to be high. You're going to be breathing likely slower or not as deep. But over here, if you're respiratory alkalosis, what are you going to be doing? Hyperventilating, breathing really quick, having a panic attack. Right. Oh, there it is. Anxiety. Now, with anxiety, we want to use calming measures to assist the patient with slower down their breathing. This patient just breathing too quick. And you've heard that term. They're blowing off. They're blowing off. They're blowing off too much CO2. It just means, folks, they're breathing too quick. So one patient over here in respiratory acidosis, they're not breathing deep enough, or they're not breathing enough to get rid of their CO2. That's respiratory acidosis. In respiratory alkalosis, they're breathing too fast, so they're getting too much CO2 out. Does that make sense? Okay, beautiful. Okay, we gotta get this down, because I cannot tell you how many messages and emails I get as paramedic coach of people not understanding this. Well, no more. Send them this video. If you're enjoying this, smash and highlight that like button. Hit subscribe. You're not going to see us anywhere else on the face of the internet on YouTube. This is the EMS mecca of education. Let's continue. Ventilator. We adjust settings to reduce the minute volume. Okay. Metabolic acidosis. It's coming up. Now, I'm going to read this out to you. A compensatory action to get rid of the body. This is huge. Well, hang with me, because we're going to get there, but I'm going to do a little preview. Okay. One of the causes of the respiratory alkalosis, which is caused by hyperventilation, it can be a compensatory action to rid the body of excess CO2 through Kussmaul breathing in DKA, and do not get confused with that. And you're not, because we're going to go over it right now. But remember this. A respiratory alkalosis can be a compensatory action because your patient is in metabolic acidosis and they're in DKA with a high blood glucose. And they got fruity breath. Fruity odor in the breath. Make sense? Okay. Here it is, folks. Oh, this is good. This is good. Okay. Now, let's get up front for this one, folks. Come to the front of the class. Metabolic acidosis is caused by a buildup of an acid or a loss of a base. Caused by a buildup of an acid or a loss of a base. Okay. The body will try to correct the imbalance with a compensatory respiratory alkalosis. So you go to a patient, they're diabetic. They're diabetic type 1 because type 1 diabetics get DKA. You go to a patient, type 1 diabetes, and their blood glucose is through the roof. It's very high. 3, 4, 5, 6, 700. It's high. It's high. Let's say it's 500. You go to the patient and they're trucking to breathe, meaning they're really breathing hard. Hard, deep, where they're breathing. We're looking at a metabolic acidosis and DKA. The breathing is not the culprits. It's what's going on in their body that is. Okay? Now, when this happens, we will get an increased respiratory rate, and more importantly, this is key, very key, with these Kussmaul respirations, we also get the actual deepness of breathing as well. They hyperventilate to reduce CO2 levels. So now you know, folks, in the body itself wants to reduce CO2 levels. What does it do? It can be a compensation move in a metabolic acidosis. Okay? You with me? Okay. So what's the key so far? I can have the pH in the body either be acidic or it can be in alkalosis. The question is, whose fault is it? why am I in an acidosis or why am I in alkalosis? Both the respiratory acidosis and the metabolic acidosis patient, they're both on the acid side of their pH, but one has it for primary respiratory cause and the other one has it for another cause, like DKA. Same with the alkalosis. The question we got to figure out when we're treating the patient is who's the culprit? And we figure that out by their story, their history, their vitals, etc. More on that in a moment, okay? What's the presentation? Chief complaint, right? Causes. Diabetic ketoacidosis. Number one, take it to the bank. This is going to be in our study guide. Remember that free study guide is in the description down below. Watch this whole video. You're going to love that. It build up of ketone bodies, okay? Also, that patient will have this, renal failure, diarrhea, because they've lost, remember, this can be because they either lost the base or buildup of the acid. In diarrhea, I can lose too much bicarbonate fluid. Could be a toxin, okay? We see methanol, okay? We see aspirin overdose. Ethylene glycol overdose can cause. Lactic acidosis, buildup of lactic acid that is produced faster than it's metabolized. Seizures, ischemia in large muscles, organs, shock, okay? All of them are true, yes, but I'm just telling you from experience that exams love DKA and everything around it. That's why I'm hyping it and really pumping it up here and talking about it. Make sense? Okay, cool. Let's continue. I got a lot more to share. Here we go. Okay, metabolic alkalosis, okay? This is the loss of hydrogen ions, which are acid, which is going to be on the acid side, okay? Which is our acidic. This is what makes up our pH, okay? So again, metabolic alkalosis, well, I just lose hydrogen ions, okay? Now, what does that mean? One of the things we look at is a metabolic alkalosis can cause a compensatory respiratory acidosis, meaning it will decrease the respiratory rate in order to retain and increase CO2 levels, which increases the acidity. Because in this case, in the metabolic alkalosis, we're on too much of a base. We're on the alkalosis side. So if the body compensates and says, you know what I want to do? I want to decrease respiratory rate so I can retain some of that CO2 and I can start to move over into normal. But the problem is we didn't solve the actual problem here. That's a metabolic problem, right? Do you see what I'm saying? Now, hypoventilation does not last, though it will eventually cause low oxygen levels, right? The body always, and we look at it in shock and so many things, the body tries to compensate, but remember this, folks, the compensatory mechanisms of the body, when the body tries to save itself, it always eventually fails. That's why we're here, to help, okay? Which will stimulate respiration, okay? Causes: excess vomiting, okay? Gastric suctioning, meaning that there's been, too much of that going on, okay? Ingestion of large amounts of baking soda or antacids. Obviously, folks, if you just dump baking soda, you get going to be too out on the alkalosis side, okay? Excessive use of diuretics, a side effect of hypokalemia. This is metabolic alkalosis. Now, I'm going to show you in a little bit here, as we go through this, all of this in action, and it's right here in front of us, okay? The acid-base imbalances. So check out my chart here, and we're going to get this down cold for the rest of our career, okay? What are we talking about? Respiratory acidosis. Why? Because CO2 is an acid, okay? So that's why if we retain too much CO2, I end up in a respiratory acidosis. What about a respiratory alkalosis? The complete opposite. That's caused from hyperventilation. What about metabolic acidosis? DKA. Oh, that's DKA. Okay, got it. Now, what about our metabolic alkalosis, which is down here? metabolic alkalosis. Okay? That is going to be too much of our base. Too much of our base. Okay? Make sense? Now again, look here what we have. Here's respiratory acidosis. So we have our acidosises and our alkalosises. Okay? The box here is boxes with this little check mark or normal values. Okay? So respiratory acidosis. The pH, more acidic? Yes. The CO2 is up. That's the culprit. Metabolic acidosis, pH is acidic. Who's the culprit? It's his fault. It's the bicarbonate's fault. It's too low. Respiratory alkalosis. The pH is up. I'm in acidosis. Why? CO2's down. It's respiratory problem. Metabolic alkalosis. The pH is up. Who's the culprit? Too much bicarb. Make sense? Beautiful work. Now, I got some examples. We're going to go through this together. Okay? I'm never leaving you empty-handed. All right, paramedic coach never leaves you empty-handed. Okay? He teaches and he gives you the study guides. Okay? So, we're going to go through the examples right now together. Ready? Let's do it. So, check out example number 1. Our pH is 7.56. Is that acid or is that on our base? Are we too high or are we too low? What do we have? What's normal? Well, normal is 7.35, 7.45. Well, that means I'm on the basic. Right. Okay, we're on the basic side. Okay. Now, do we remember our other values? Okay, 35 to 45 is normal CO2. Oh, I got a culprit here. 22 to 26 is normal on our bicarbonate. This means I got an alkalosis and and respiratory is the culprit. Okay? So there's number 1. Let's do number 2. Number 2, pH. pH, is it too acidic or is it on our base side? Look at it. Well, 7.35, 7.45, 7.25 is low. Look at the CO2. Man, CO2 is high. Okay, well the CO2 is off. And the HCO3 is normal limits. What do we got here? Well, we got a person who's retaining CO2. So the CO2 level is high, which means we have the pH is going to be low. It's a respiratory acidosis. Okay, pH 7.56. We got a normal CO2 and we got 35 on bicarb. So we have the bicarb's too high and we got an alkalosis. There it is. It's a metabolic alkalosis. And finally, I have a patient who is in an acidosis with a normal CO2 and I got 20 on my bicarb. Bicarb's a little low. What do we got? We got a metabolic acidosis. And check it out here, folks. Okay? And folks, again, these numbers are made up to illustrate the acid-base principles. So don't take them to heart. These are just to explain to you the process. Okay? And we can see here on the screen here. Okay. So, folks, in summary here, we're talking about capnography. And remember, folks, this is the beginning of this video. Okay? We are going over all the categories. This is only the first. Okay? So stay tuned, smash that like button, share this video with a friend, let's go, okay? Now, capnography can provide an alternative and non-invasive way to gather the acid, base, and metabolic status of a patient, okay? I think we understand it by now. Now, folks, the PCO2 is always at least as high as the end tidal. That's a big pearl. So meaning, folks, if the end tidal CO2 is high, the PCO2, the arterial blood CO2, is definitely elevated. And it could represent a respiratory acidosis. If the end tidal CO2 is low, the PCO2 is at least as high as the end tidal, but can be greater based on the patient's perfusion status. It could represent a respiratory alkalosis and or a low cardiac output. Again, it's a supplemental tool, but I want to say a great tool to combine with the patient's history, signs, symptoms, their chief complaints, and their assessment. And now we're moving on to our next chapter in this video, cardiology, which is literally the reason why people become paramedics, is to learn this cardiology, is to become a master of cardiology. We carry a heart monitor. It's our main piece of equipment. We cannot pass National Registered Paramedic if we struggle with cardiology. So if you ever struggled in cardiology with school, let me go over the main factors for you right now. And we're going to start here with our EKG wave. Let's go. Cardiology, again, makes the paramedic. We're going to start. I want to make sure that you're aware of all our EKG waves. We're going to get into 12-lead EKGs. Hang with me. And again, everything you're seeing here is in your free study guide after you've watched this video here, okay? So you're going to have questions and you're going to have everything we covered here. So watch this video over 2, 3, 4, 5 times. It's here on YouTube. It's free. You can watch it 100 times. Okay, all the information's here. You watch this, you watch this. This is the high yield stuff you gotta know for that National Registered Paramedic that I want you in that comment saying, Evan, I passed. Let's go. All right. Here's our cardiac cycle. So I just want to review here that the P wave represents the atrials depolarizing. So we have depolarization and repolarization. Depolarizing means the electrical current is going through that part of the heart at that time, producing a wave. Okay. Repolarization is the resting state of whatever wave or part of the heart I'm talking about. The electrical activity of the heart is represented by the EKG. A P wave represents the atrial depolarizing. It is the first wave of an EKG, okay? The first wave, yes, and also, more importantly, the first positive deflection on EKG, meaning a positive wave points up, and like a Q wave is the first negative, it points down, wave on an EKG. Now, remember, when we have a patient, the QRS complex is represented as a complex of 3 different waves. The first negative deflection is Q. The second positive deflection on the whole EKG is the R wave. And the second negative deflection on the whole EKG is the S wave. The QRS combines to make a complex called the QRS complex. This complex represents ventricular when the ventricles depolarize, when electricity is going through the ventricles. Don't forget our PR interval from the beginning of the P to the start of the QRS complex, and the ST segment from the end of the S to the beginning of the T. The ST segment is where we look for elevations and depressions, and we look to see if we have 2 or more contiguous leads on a 12-lead EKG. More on that later. The T wave represents when the ventricles relax or repolarize. When I look at a 12-lead EKG, important tip, I always look at this line before the P wave, not here, to determine if my ST segment is up, down, or normal. Why? My PR interval can be depressed, like in pericarditis, for example. You get PR depression sometimes, okay? So I never look here and look here. I always look in front of the P or in front of whatever I'm working with. But I always look at what I'm trying to say is I always look at the isoelectric line and confirm across. Make sense? Okay, beautiful work. So we've talked about this. The P wave is atrial depolarization. The PR segment is the delay in the AV node. Okay, the AV node has the slowest conduction speed and allows for the atrial contraction and ventricular filling. That's our PR segment. Our PR interval, okay, a PR interval is the atrial and the AV node activity, okay? It's composed of the P wave and the PR segment. The normal time is 0.12 to 0.20 seconds, okay? Our QRS complex is ventricular depolarization, okay? Our Q, our R, our S is the normal number, somewhere between 0.08 and 0.12, okay? Seconds, that is our normal QRS. We go above 0.12, it's wide. It's a wide complex. Okay, ST segment is between the S and T. That's important for 12-lead EKGs in a little bit. Our T wave, this is where refractory periods can occur, okay? You may have heard about R on T phenomenon, okay? Meaning, if we have an impulse, like a PVC, for example, and it strikes on that T wave on a certain part, we're going to talk about it, of the T wave, we can have VTAC happen and cardiac arrest even happen like that, okay? Or a force applied. Then finally, the one that's never talked about a lot is the QT interval. Well, it's ventricular depolarization and repolarization, so it's all the ventricular activity. A normal QT interval is actually 0.35 to 0.45, and we have prolonged in males would be above 0.44, females would be above 0.46, and there's a risk of arrhythmias if it's over 0.51. Who's at risk in this? We think about young athletes. You see these young athletes, they're in a game and then all of a sudden they're going to cardiac arrest. It can happen to do with this QT interval. We've seen these in sports happen with RNT phenomenon, et cetera, et cetera. That's for another video, but in this case, for folks in NREMT, we need to know this as a basis for cardiology. Now, I want to talk to you. We're going to go through now. I'm going to put a bunch of EKGs on the screen, okay? Now we can see this, I have it labeled, okay? We're going to talk, I'm actually going to put this away for the moment, and we're going to talk about the EKG. Me and you here, like I'm your instructor, okay? You have a patient here in atrial flutter, okay? Now this is not a rapid atrial flutter. I can look at the R to Rs, and I can see here, well, the rate is somewhat normal just by taking a look at it, okay? It'd be much closer together if it was fast. But we can clearly see from the sawtooth pattern that I have an atrial flutter patient. Here's what I want to share with you. Pretend for me for a moment that this A flutter was rapid. You have a patient in a rapid atrial flutter. The heart rate is 180, okay? Let's say. They call the ambulance, chest pain, difficulty breathing. You put them on the monitor. I see rapid A flutter at 180. You get vitals. You talk to the patient. What do? If you have no idea, I can tell you right now, you will not pass. There's no way you'll pass the National Emergency Paramedic. No way. That's why I've chosen the most important EKGs. We're going to go over here. And we're going to talk about what we've learned, I hope we learned, okay, in paramedic school, ACLS. When I see a bad EKG, is the EKG stable or is the EKG unstable? Okay, hang with me. You got to know this, folks. Listen to me here. If I see somebody here with a flutter, okay, and they are stable, on the stable side, first off, how do I even determine if a patient is stable or unstable? Two things. The patient's mental status, the patient's blood pressure. That's it. If you want to throw in a bonus, you can say what their chief complaint is, but honestly, I'm not too concerned because if their blood pressure or mental status suck, I don't care what they're complaining about. I know they're unstable. Does that make sense? Right? Now, so really we look at the blood, please remember this, you have to remember this, you must. Blood pressure and mental status determine if you're stable or unstable. And folks, this is why when we think about, we're obviously watching this as a paramedic and we're getting ready to become a paramedic after watching this video. When we talk about at the EMT level, why do EMTs call you as a paramedic? They call you as a paramedic because the vitals are unstable and they don't know what to do because the patient's unstable. So in this case, you go to a 56-year-old male patient and they have chest pain, difficulty breathing, and they're in a rapid A flutter at 180. If I told you that their systolic blood pressure was in the 80s, the mid 80s, and I told you the patient was normally GCS 15, ANO times 4, but now the patient's confused and they're semi-responsive. Is that patient stable or unstable? He's unstable because of his blood pressure and his mental status. But with that same patient I told you was alert and awake, but had chest pain and a little bit of trouble breathing, but their blood pressure was, let's say, 160 over 90, right? Well, that patient will be considered stable. And for all these different scenarios that we see, if the patient's blood pressure and mental status are stable, then what we do is we get to give them medications. If they're in a lethal or really bad EKG, we'll talk about it, okay? If they are unstable, what do? We use electricity. We're going to use the life pack, the heart monitor, to do some sort of electrical activity with them, either defibrillation or cardioversion or pacing, depending on what the rhythm is. You have to understand this before we move on. So now let's talk about a flutter itself. We've kind of set the groundwork for all these EKGs. Now, with a flutter, what do we have? With a flutter, it is under the realm of a supraventricular tachycardia, meaning it is, if you look at you can see here those QRS complexes, they're not wide. It's an atrial rhythm. It's an atrial rhythm, right? So we know that the impulse is supraventricular in nature, meaning that, well, it's an atrial rhythm, it's a flutter, so the impulse starts above the ventricles, is what we're saying, right? So in this case, if the patient's stable, we would give them either a calcium channel blocker or a beta blocker. This could be like low pressor, 5 milligrams, right? IV. Another example, we could give this patient a calcium channel blocker. That would be like diltiazem at 15 milligrams IV, right? So this patient is either getting beta blocker like low pressor, metoprolol, or they're getting Carbazem, diltiazem, calcium channel blocker as their first line medication. And the stable side, if they're unstable, we have to synchronize cardiovert this patient. If their blood pressure is in the toilet and they're really confused or they're not even responsive, okay, we have to go ahead and synchronize cardiovert with the life pack. Now for a flutter, a fib, okay, our synchronized cardioversion is going to be about 120 joules, okay? So that's what we're looking at here. Let's move on to our next EKG and let's do it. Okay, so next up, this is our EKG here of atrial fibrillation. Again, we see the rate in this particular EKG is a little more slow. Notice the difference between a flutter and a fib. A fib, look at all these fibrillatory waves. Look at all those fibrillatory waves in between, right? See, a flutter has that sharp tooth appearance between the waves, but if you look at a flutter, we just see a bunch of, they call them, F waves, fibrillatory waves. Basically, if I took away these QRS complexes, it would look like V-fib, wouldn't it? That's the way to remember it, okay? So, if we look here at atrial fibrillation, the impulse starts, it's supraventricular in nature, it's not a ventricular rhythm, it starts in the atria, it's a flutter. I have a QRS, but look at my atrium, it's really messed up because it's just, my atria is going like this, my ventricle is going like this, right? And you can see the hallmark of this EKG, it's irregularly irregular in the rhythm. Now, if this rate, let's say again, was 180, 190, 200, 170, go to the patient. If they're stable, we give medications. That would be a beta blocker, calcium channel blocker. Same thing as the A-flutter we just talked about. And again, same thing with AFib, 120 joules, around there, synchronized cardiovert. If they're unstable, they need a synchronized cardioversion. Same rule applies here. That's how we treat AFib in the field as a paramedic, okay? When it's rapid. Remember, I'm talking about when it's rapid. So if we go to a patient and they're in AFib at a normal rate, we don't give them meds. We don't shock them. Remember, folks, we're going to synchronize cardiovert, and we're only going to give medications. Why are we even giving the medications? Well, the reason is the heart rate's too high. That's why. So beta blockers, calcium channel blockers, bring the heart rate down. Why are we synchronized cardioverting somebody with a blood pressure that's low? A synchronized cardioversion, it restarts the heart to bring the heart rate down. But if I go to someone who's in AFib and their rate is, let's say, 110, 120, 80, we don't do any of that. We treat the patient's signs and symptoms, do a 12 lead, and we do routine ALS, and maybe they just happen to have AFib, but they have they have an arterial bleed. Treat the arterial bleed. Get what I'm saying? So one sense I want to give to you is, with your patients, you have to identify what is the primary culprit. Why are they calling 911? Why are they sick or why are they injured? And as paramedics, we treat that. As a paramedic, we have more tools to do that. Does that make sense? Okay, good. Okay, this is the definition of a supraventricular tachycardia. It is supraventricular tachycardia. The EKG is called SVT. Here it is. Okay, and we can see here again, narrow QRS, narrow QRS. Okay, this is a beautiful looking SVT here. Not beautiful for your patient, but a good tracing for us to learn. Now, remember with SVT, remember I talked about on the unstable side, right? The unstable side, what do? Well, we know we're going to synchronize cardiovert if an SVT is unstable. But what if it's stable? Well, we do something different. It's a chemical cardioversion. The drug is adenosine, meaning we give the medication adenosine, 6 milligrams, followed up by 12 milligrams, IV, right? Adenosine is given. Remember, we don't want it, every cell wants that adenosine. I want to get it high up in the AC. I want it high up here. I want it high up here, okay, for my IV. Adenosine is what we call a chemical cardioversion. It's the medication route of resetting this rhythm that's too fast. We're giving the medication to lower the heart rate. I would love to convert this to a sinus tach, or I love to convert this to a normal sinus rhythm. That's what I'm trying to do. Or whatever the patient's normal underlying rhythm is. But they're not knowing walking around at this, they wouldn't be alive very long. That's why they call the ambulance. Make sense? Okay. They're unstable, meaning their blood pressure and their mental status are in the toilet. They're confused. Okay. Their blood pressure is below 90 systolic. Their mean arterial pressure is probably under 65. Then we synchronize cardiovert. For SVT, 50 joules, we can start 100 up to 100 joules, work our way up. That works, okay? So remember, either med stable or energy. What are we doing? Give me a blood pressure, give me a mental status. Yes, give me a chief complaint. Thank you, sir. Thank you, ma'am. And then make a decision. Is that fair? Beautiful work. Let's continue. Okay, now these I just want to highlight because so many paramedics have a hard time with heart blocks. I hate to see it. So I'm like, you know what? I'm going to throw this in the presentation for fun. There's not much nuance with heart blocks as far as treatments. I want to focus on the identification. So With heart blocks, folks, all it is the PRI, the PR interval. It can only do a few things, okay? Well, in first degree heart block, okay, the PR interval is just too long, okay? In second degree type 1, I'm going to show you in a moment, the PRI, it gets longer and longer and longer, and then it drops the beat. It drops the beat, okay? In second degree type 2, the PRI is constant. The PRI is constant. And then it drops the beat. It just drops the beat. Okay, I'm going to show you. In third degree heart block, nothing makes sense. Third degree heart block, nothing makes sense. Nothing makes sense. If you remember that little performance I put on for you, you'll never ever forget heart blocks. Notice here, this looks like normal sinus rhythm at first glance, but look how far out the P waves are. Every P has a QRS. It's just a variant of old age usually, is a first degree heart block. So look how far away the P wave is from the QRS. Just looks a little odd, right? But every P has a QRS, meaning every heartbeat is going through. But it's just the PRI is a little long. It's over 0.20. We're not going to do anything for this besides say, hey, you know, has your doctor ever, you know, said he had a first degree heart block? Yes or no or okay. Well, just to make sure, sir, we're going to do a full EKG. Do a 12 lead. That's it. Monitor the patient, take care of signs and symptoms. I mean, that's it. That's about it. It's not a primary heart problem going on today. Unless the 12 lead is something crazy, okay? Now look here at second degree type 1. We can see here the PRI gets longer and longer and longer, and it drops the beats. Look, that P wave's got no QRS attached to it. That P wave's got no friends. Then the process restarts again, okay? This looks more like this, right? So, P wave, QRS, P wave, QRS, P wave, QRS, P wave, where's my QRS? That's a longer drops, second degree type 1. Now, what do we do with second degree type 1? Now, can I still give atropine to this patient? Again, we look at. Now we start looking at treatments. Okay, second degree type 1, that's not normal. Stable or unstable? Okay, if they're truly unstable in their blood pressure mental status, and they have, you know, cardiac related complaints, this is a time where either you could pace the patient. Sure. Okay. This type 1, in the simplest way, is a little better than type 2 only because we can still use atropine in a type 1, but in a type 2 or third degree, atropine doesn't work. So the only treatment option we really have for type 2 and type 3 is to pace the patients. So we have to be pretty sure before we go doing that, right? Right. Look at type 2. Remember, it's constant. The PRI is constant. It's constant until it drops a beat. Look, P wave, no friend. The QRS is gone and it goes back to what it was doing. Oops. And it goes back to what it was doing before. Got a little preview there. Make sense? Make sense? Okay? Constant. It drops. Constant. And then you can see our P wave over here all by itself, it drops again. Okay? Now, second degree type 2, stable or unstable, what do I do? Oh, I don't have atropine. I got no meds. So the only thing I can do is pacing. That's it. Third degree heart block. Nothing, I told you. Nothing makes sense. Look at this. P wave, QRS. P wave, P wave, QRS. P wave, P wave, QRS. P wave. Nothing makes sense. It's called AV dissociation. There's nothing here makes sense. The P wave, meaning the atria of the heart, is not talking to the ventricles, and they're all firing at their own rates. It's like a third-degree heart block is a wild, wild west of electrical activity. What do we do with this? If this is wild, wild west, pace that, baby. And that's what we're going to do if we see a third-degree heart block. We're going to pace that, baby. Okay? I doubt your patient is going to be stable and alert on the couch with a GCS 15, right, with a normal blood pressure in a third-degree heart block. That's very unlikely, okay? So in reality, then they're going to be unstable with their vitals, and you'd pace the patient. Make sense? Good. So now we're going to talk about VT, ventricular tachycardia. When we see VT, we first must think, is it pulse or pulseless? Obviously, folks, if we have a pulseless patient has no pulse and they're in VT, we're at a cardiac arrest. First thing we're doing is CPR and then following that up with defibrillation. Okay, that's energy. Now, if we got a pulse, then we're going to do stable or unstable. Stable, meds. Unstable, that is your energy, but different energy. If someone has a pulse, we never defibrillate them. It's going to be a synchronized cardioversion, a synchronized shock. Again, it would be about 100 joules for this case, ventricular tachycardia, if they're unstable. Why are they unstable? Blood pressure, mental status. Okay? Now, unstable for this patient. Now, it is not impossible. Obviously, it's rare, but again, NREMT can throw anything at you. A patient has a pulse, their blood pressure is okay, their mental status is okay, and they're in VT. Now, I've seen this happen before in the field. That moment is like literally like a moment in time, and they're in cardiac arrest, okay? But it can happen. In that moment, what would you do? Well, the drug of choice obviously is going to be amiodarone. So it could be an amiodarone drip at 150, for example, right? That could be our drug to drip in, okay, for VT. Now, let's go on to the next one here. VFib. VFib always has no pulse. So VFib, we see VFib, immediately jump in the chest, CPR, defibrillation, word to cardiac arrest. That's going to be your epinephrine later on, right? That's going to be amiodarone, continual shocking, setting up an airway down the line. You're in a cardiac arrest. Simple as that, okay? That's ACLS 101. Now, here's the bonus one, our last EKG I want to touch on, because it's sneaky. Torsade de points, okay? Torsade de points. Now, with torsades, it looks like VT, but it's a type of polymorphic VT. Look here, folks. Look at this, how it winds, and then it goes down. Then it winds up, and goes down. Then it winds up. That pattern is torsades. This patient needs magnesium. Magnesium at 2 grams. And again, if this patient was awake and stable, 2 grams, we can drip it in. If they're unstable, we're going to shock. And I honestly still want to give magnesium, okay, as well to this patient. So just remember this. This patient needs magnesium at the baseline. Mag, 2 grams, 4 torsades. Pretty cool? Okay, beautiful work. So what I have for you here, this is our normal 12-lead EKG. We gotta know what normal is first. So I first just wanna go with you and I wanna go lead by lead, okay? So the bottom here is lead 2. Remember when you read an EKG, a 12-lead EKG, that lead 2 is where you do your rhythm recognition. So when you put down a 12 lead, look at lead 2. Lead 2, you first determine what is the underlying rhythm of the EKG. Then we look lead by lead to determine is the ST segment elevated or depressed, right? And remember, I'm going to give you a reminder right now of who are friends. What does elevation depression look like? Which arteries sync up with each lead? Let's start with that and we'll get more advanced, okay? Now look here. Lead 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. This bottom one is an entire strip of lead 2, okay? Lead 1 and AVL, they are friends. They are contiguous leads. Meaning, if I see ST elevation in 1 AVL, I may have a heart attack going on, right? ST segment elevation, okay? Now, lead 1 and AVL are friends. They look at the lateral wall of the heart. Lead 2, 3, and AVF, they are friends. Remember, we only need 2 or more contiguous leads. If I got 2 up and 3 up, that's enough. I can call it, okay? 2, 3 AVF looks at the inferior part of the heart, the bottom. Now, AVR has no friends. AVR has no friends. This is for advanced discussion, okay? I do offer a 12-lead EKG masterclass. We get into this advanced discussions. If you want to really go crazy on EKGs, you check that out. V1 and V2. V1 and V2. That looks at the septal wall, okay? V3 and V4, what is that going to look at? That is the anterior or the front of the heart. V5 and V6, that looks at, again, the lateral wall of the heart, the sides, okay? So, now we know our players. Let's talk a little more. Now, again, here we go. These are all our infarction locations. So, lateral, inferior, no friends, AVR, save you for advanced land, V1, V2, septal, V3, V4, anterior, V5, V6, lateral. Remember, folks, the National Registry Paramedic exam is not trying to see if you're an advanced cardiologist. It is trying to see if you are a competent paramedic who knows when there's a clear-cut heart attack going on to open the cath lab and to call a STEMI alert and go lights and sirens to the hospital. And that's what we need to make sure we know. Make sense? If you want advanced stuff, I got you too, but let's focus on the stuff we must know, and then we can build, okay? Now, here is a view of the heart. This is one of my favorite slides. It shows the artery. This is a great test question. The artery that is involved in the actual heart attack. The inferior wall affects the right coronary artery. That's 2, 3 AVF, okay? The septal wall is the left anterior descending artery, the LAD, V1 and V2. The lateral wall, that's our LAD, the left anterior descending artery, but we also get a branch off into the circumflex branch, 1 AVL, V5, V6. Anterior wall, clear cut, LAD, the widowmaker, the LAD, the left anterior descending artery, okay? So now we know, we got it down cold. We stamped that down. Let's move on, okay? Now we can see here a little graph for you of everything that's affected, okay? 2, 3 AVF, inferior right coronary artery affected. 1 AVL, V5, V6, lateral, LAD, circumflex branch. 1 AVL, high lateral, LAD. V1, V2, septal, LAD. V3, V4, anterior, LAD. Whoop, I got a new one. I go to a patient. They have inferior wall MI. What's the next thing you must do? Open the cath lab. That's nice. Give aspirin. That's nice. All right. But I want you to do a right side EKG. Why? V4R, V5R, V6R. When we move the leads over, look at the right ventricle, we can have a right ventricular infarct. And that also affects the right coronary artery. So if I got an inferior, I may have a right ventricular infarct. I might. Okay? Check for that. Okay? One little pearl I want to give you real quick. This is a little sneaky. I doubt National, again, going into advanced land, but we still have to know this as a paramedic. I'm just saying, National Registries focus on the most high yield stuff, not these gotcha stuff, but I'll just share it with you because I want to give you a little pearl. Folks, if you see an EKG, sick patient, V1 and V2, you have ST depression, and I don't see any elevation on the EKG. Folks, you need to do a posterior. Move those leads to the back, do a posterior EKG. If you move these for the right side, I usually move leads to the back for a posterior EKG. Why? You might have a posterior MI. Okay? So that's something sneaky that you might see. V1 and V2 are depressed, and everything else looks okay. Look out for a posterior. Okay? That's a big pearl. Now, ischemic changes on EKG. I look at the ST segment. I can have elevation or depression. ST segment elevation can mean many things, but in this case, I'm just focusing on what we must know about understanding the 12-lead EKG for heart attacks. Depression. T waves. We can have an inverted T wave, a peak T wave, a flat T wave, right? The Q wave can be deep and wide. We can have the loss of an R wave, resulting in a deep QS wave, so there's no positive deflection on the QRS. It's just a big fat Q and S. Okay? Now I want to read this to you, then we're going to talk about some of these things. In partial wall thickness infarctions, damage may be insufficient to produce abnormal Q waves. These are called non-Q infarctions. A little pearl. I wanted to touch on some of this stuff. Folks, if I see widespread ST depression, my heart, there is ischemia. The artery, I think about it like it's being choked. When I have the full elevation, like a full STEMI, like a full MI, then I have a blockage where literally my heart is not receiving any more oxygen, okay? So we could start off with, for example, flip T waves, some ST depression, and as we keep producing EKGs, the ST elevation is born. Same thing with these peak T waves. We can start off with peak T waves that end up, and we end up with ST elevation on top of that, okay? Now, let's move on, okay? This all making sense? Okay, good work. Okay, now, this is an important slide. You gotta know what this looks like, okay? This is our normal ST elevation, abnormal Q wave. So we can see here, P, QRST, beautiful. There's an example of T wave inversion, a flip T wave. A flip T wave, widespread. We're seeing it doesn't have to be every lead, but let's say we see multiple leads with, let's say we saw 2 or 3 or 4 or 5 different leads with ST wave inversion. That is a sign of ischemia, okay? Ischemia. Same as ST depression. Look at that J point, which is the point of which our ST segment is either up, down, or okay. In this case, it's down. Look how far down. Here's our ISO. Remember I told you earlier? Here's our isoelectric. Now look at the J point. Up, down, or okay. Down. That's sign of ischemia. Now, ST elevation, here's our isoelectric right here. There's our ST elevation. And there we can see a clear cut. Okay, here's our abnormal Q wave. We can see, look at that wide Q wave. Okay, you can see that. And here's our deep QS wave. Notice there's no R wave. It's deep QS. Basically, essentially, 2 negative deflections make 1 deep QS wave. Make sense? Okay, good work. So now, I want to show you 2 EKGs, 2 12-lead EKGs, and we're going to break this down. And we're going to go lead by lead together right here on YouTube. And we're going to go lead by lead. Me, myself, paramedic coach. You ready to go? Let's do it. Okay. Smash that like button, folks. Hit subscribe if you're enjoying this. This is your EMS education hub on YouTube. Let's go and really all over the internet. So here we go. Lead one. Lead one, up, down, or okay? Up. Lead two, up, down, or okay? A smidge down. Smidge down. Lead three, down. AVR, got no friends? We'll save you for another day. AVL, up. Now, I can already see here, we have 2 up and 2 down, which is the criteria for a STEMI. But let's continue. AVF, down, okay? Hey, call the cath lab, okay, right? V1, down. V2, down. V3, down. V4, V4, slightly up. Smidge up. I don't like that T wave. If you see a T wave that's almost as tall as the QRS, or if you see a T wave and go, man, it's really pointy, that gets me a little nervous. So watch out for that. Okay? That's, I would say, up. That is definitely up, and that's definitely up. And notice how it kind of swirls in as we get into the lateral leads. So folks, we have both lateral leads here with elevations, and we have it in the reciprocal, which is the inferior of our lateral, is down. This is a lateral STEMI. As a paramedic, you need to open the cath lab, do your aspirin, do your nitro, treat your patient. IVs, pain meds, transport your patient. Keep burning 12 EKGs, see what changes. What's going to solve this patient? The cath lab is going to solve this patient, okay? Get this patient to a cath lab. Now, next one. Here we go. Ready? Let's do it. Okay. Up, down, or okay? I want to say it's a smidge up. A smidge up. A smidge. V2? V2 looks pretty straight on. Pretty straight on. Okay. V3? Down. AVR? No friends, we'll hang up, don't worry about it. Now AVL, up, up, 2 up. Okay. That, again, that could be an inch down. That's down. That's definitely down. Notice how this EKG this is more of like we see in real life sometimes, and we see crazy clicker ones too. But see how distinctive these can be, right? Now, we're not done yet, but we're just starting to look. We got some trouble ahead. Look at V1. That's up. Look at V2. That's up. Look at V3. That's up. V4. That's up. V5. That's up. And V6. That's up. So the concerning thing that we saw here trended into a massive anterior STEMI here. And we can even see a little bit of lateral involvement in this. Does that make sense? Okay, beautiful work. So how do we have to do that together? Now I want to touch on, again, when I make these presentations, I always think about, hey, what questions and messages do I always get as paramedic coach? Your emails and your messages and your comments. And like acid base from paramedics, I get asked a lot about bundle branch blocks. So I'm like, it's going in our NREMT, NR-Paramedic video. So bundle branch blocks, it originates in the bundle branches. So remember, folks, the heart, we have the SA node. We go through our pathways, through the atria. We end up at the AV node, bundle of His. Bundle branches go through each of the ventricles, or right and left. And then we have the Purkinje fibers at the end, at the bottom of the ventricles. So I'm basically having with a bundle branch block. What I'm having is a delay or a block or a slowing in the impulse in the bundle branch. So here we go. It's a lesion in the bundles. It will cause a delay of the impulse in the affected bundle branch. This is why there's a wide prolonged QRS complex. So if you look at an EKG and I go, that's a wide complex QRS. Is this ventricular? But then you're like, well, I see a P wave. It's a bundle branch, right? It's likely a bundle branch block, okay? We're going to talk about this. Well, a wide QRS complex, but it's got a prolonged QRS duration, okay? Remember, a ventricular rhythm wouldn't have a P wave, okay? Let's continue. Now, how do we tell, this is the big question I always get, between a left and a right. I'm going to show you something in this video, you'll never forget it, okay? First, I want to show you what it looks like in practice, and then I'm going to give you the easiest tip, you're going to love this. So left bundle branch block. When I look at V1 with a left bundle, it's typically a deep S wave, and it looks like this. When I look at a bundle branch block in V6, it looks like this. It's a giant R wave, okay? When I look at a right bundle, it looks like a classic bunny ear pattern. They call it RSR. So it's basically up and down and up and down and up. That's the right bundle, okay? So here we go. We're going up and down and up and down and up, and then up and down and up. And that's the right bundle, okay? And we haven't even gotten to the mnemonic yet. I'm just having a good time, all right? We guys having fun? Come on, I'm loving this. Now V6, deep as a deep S wave, a deep S wave, a deep S wave, a deep S wave in V6. So with that being said, folks, if I go back, actually we'll go forward. If you notice, we're driving the car, okay? I'm driving my car. I'm going to try to get this angle for you here. If I'm driving the car, here, let's say here's my turn signal, okay? And I'm thinking about lead V1. Here's my turn signal, okay? I'm driving my car, okay? If I put the turn signal down to turn my car to go to the left, because the left bundle, what happens? I push down. Well, in V1, we have the terminal deflection of the EKG pointing down. But if I'm back in my car and I want to go right at my turn signal, I push up because the terminal deflection of the right bundle is going to be up. That's how you remember it for the rest of your career. So now when you're driving and you want to go left, push down on your turn signal, I want to go left, what are you going to do? It's a left bundle in V1. Now it's, I want to go right, I push up my turn signal, up. It's a right bundle because the terminal deflection is up. Okay, so look here. Left bundle branch block and lead V1. In the car turn left, you bring the signal down. Boom. Left bundle. Points down in V1. And there it is. Pretty cool? And here it is. Here's our right bundle, lead V1. In the car, turn right, you bring the signal up. RSR, taller on the right. We can see it here, okay? Boom, 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 boom. That's the bunny ear pattern that we get in V1. Make sense? Because the terminal deflection points up with a right bundle, but it points down with a left bundle. So here we go. Left bundle V1, right bundle V1, and there it is. Pretty cool? All right, let's do it. Hope you enjoyed that little mnemonic. Let's go. If you don't know yet, our flagship program, the Video Vault program, that link is down below in the description. 480 videos of content, 2,000 practice questions, and lifetime access. You can learn more in the description down below. And now we're going to get into mean arterial pressure. So now we're going to get into our next segment here, which is going to be talking about something very important. Fluids with trauma. Fluid resus. I got a lot of pearls to share with you. We're on our third category. If you're enjoying this video, smash an I like that like button, hit subscribe, and drop a comment. Got questions? Tell me what you're working on. I'm here to help. Let's get after it. Let's continue. Come on. Okay. Now, when we hear mean arterial pressure, what do we think about? Well, we think about fluid recess, fluids, yes. We think about what does the pressure have to be in your arteries in order to pump enough blood and oxygen to keep your organs alive. That's what we think about. This is why we say, well, when we're doing recess on a patient, yeah, it's nice to see 90 systolic, but we really want to see a mean arterial pressure of at least 65. That way, we perfuse the organs, or we hear the term permissive hypotension, right? Which basically is saying, in other words, I care more about your mean arterial pressure than I do just the systolic blood pressure. It must be 90 and above, right? This is okay. So in reality, the mean arterial pressure is pretty much the most important number that we have as far as how much fluids do we give and when we stop giving fluids. Well, here it is. What is it? It's the measure of the average arterial pressure in one cardiac cycle, okay? Your blood pressure reading will give you this. The map, a mean arterial pressure of greater than 65 is required to perfuse organs. So we must get a map of 65 or better to perfuse our organs. That's our target of fluid recess. For example, I give fluids to a patient that's, let's say they have a really bad bleed or they're severely dehydrated. Their blood pressure is low. I do a blood pressure, let's say in 15 minutes, and their MAP is now 70 or 72. I'm going to say, good work. Let's maintain our gains. We don't need to pump more, pump more, pump more, right? Because why? Folks, the fluids that we give our patient, okay, now in some areas we do give blood in the field. I'm ignoring that for this moment because not everyone in all EMS does that yet, okay? Now, when I give, and also now everyone needs blood also. If there's dehydrated and you just need fluid. Anyway, I digress. With this patient, let's just say, for example, they were bleeding out. We just want to bring up the fluid in the body enough to where they're perfusing their organs. We don't want to put so much fluid in that they have more IV fluid than blood. That makes sense? Okay, cool. This is what we talk about. It's a better tool to assess perfusion than systolic blood pressure because this is the actual number that perfuses the vital organs. Got it? Beautiful. Okay, we got that down. Now I got a little cool animation for you coming up, all right? So hang with me, all right? So mean arterial pressure in fluid recess. We want to maintain a map of 60 to 65 to perfuse our organs. We've all heard that before. Systolic of 90, map of 60, right? Okay? We do not want to overflow the patient with fluid. So how do I figure out the map? Could this be a test question? It sure could be. The diastolic pressure plus 1/3 of the systolic pressure minus diastolic is your map. Okay? Now, for example, if a patient has a blood pressure of 80 over 50, what is the map? Here we go. The map is going to be, what is 1/3, 80 minus 50? We get the map. Okay, there's our 50. So 80 minus 50, we have 30. We have our 1/3 and our 50. Everything's lined up. Okay, the diastolic pressure, 50. Systolic pressure, 80. Diastolic pressure, 50. I do an equation here to 30. Okay, I still have my 50. I still have my 1/3. Hang with me. Okay, basically this is saying, what is 1/3 of 30? That's 10. Okay, okay. 50 plus 10, map of 60. See how we did that? A little med math for you, folks. All right. So there it is. Now the cool thing is, if you get a blood pressure with the life pack, is it for you? But just in case, and it's not a bad thing, honestly, to get Get a real blood pressure, not that monitor one, right? Get a real blood pressure, a manual blood pressure, right? Get a real one, not that monitor, right? As you hear people say in the field, which is true, okay? Nothing like your own ears. Getting a real blood pressure, right? You can do it yourself on quick, napkin math, okay? Or glove math, quick glove math. Pretty cool? I love it. All right, good work. Now here it is. A little tip. Although systolic blood pressure is below 90, the MAP is in a good range for fluid recess. And this is why I'm showing you this here. That even though they're 80 over 50, the MAP is 60. So as far as fluid recess, they're actually in the 60 to 65 zone. So we don't get a dump. We want to maintain their fluids, right? It's not like we're just going to stop. But what we're saying here is we don't need to, more until this MAP becomes 90, right? Okay, good. So let's talk a little bit about fluid therapy for burns. So major burn injuries cause all capillaries to lose the ability to retain fluid. It's increased capillary permeability. Hang on one second, folks. I'm going to repeat that for you. This is very important. Now, we're all taught in school, oh, we got a burn patient. We got to do an equation for fluids. Oh, we got a burn patient. They need fluids. Folks, just told you why, the why behind it. When you have major burn injury, it causes all capillaries to lose the ability to retain fluid. That is why you lose so much fluid with burn patients. And that's why we give them fluid. Now you know why we do all this, okay? So when you think of a burn now, you're going to go, oh, shoot, we got a major burn patient. Their capillaries are going to lose all ability to retain fluid. I better give them some fluid. And you'll remember this video, okay? It's increased capillary permeability. There's no osmotic gradient between the vascular and extravascular spaces. Colloid solutions are able to cross the capillary membrane. It continues for about 24 hours after the injury. Now, we got a lot to break down here. I'm going to read this off. I want to make sure this is implanted in your head. You can just listen, hear my voice. You can go back. You can replay it again over and over, whatever you want to do. But it's all the info is here. So let's go. The goal of burn shock in the first 24 hours is to support perfusion of vital organs. Crystalloid solutions, hang with me, is a fluid of choice during the initial fluid recess. Lactated ringers in burn patients is preferred over normal saline because it decreases the risk of acidosis. Oh, really? That might be a question on my National Rescue Paramedic when I have a fluid choice. Maybe I'll go with ringers in burn patients over normal saline, okay? The amount and type of fluids required in the first 24 hours differ from those that will be administered afterwards. Fluid therapy is determined on the patient's response to burn and treatments. Okay? Makes sense? All right, beautiful work. Okay, now I got some burn formulas. This is where we're going to pay attention. It's not that hard. Just hang with me. Don't get scared. Okay, listen here. The Parkland formula, 4 mLs times the total burn surface area times kilograms. The consistency formula, 2 to 4 mLs times the total burn surface area times their weight in kilograms, okay? Remember, any math we do, we're always converting our pounds to kilograms, okay? Very important. Now, for both within 24 hours, this is the big key. 50% of the calculated amounts should be infused in the first, 8 hours? This is big information. Jot this down. 25% of the calculated amount should be infused over the second 8 hours, and 25% of the calculated amount should be infused over the third 8 hours. Remember, this whole process we talked about with our capillaries and our volume, our fluids, is all in the first 24 hours. So we're supporting the body with fluid over that first 24 hours. So think about it, folks. That burn patient, you think those burns look bad? If they don't get this fluid, they're not going to make it. Does that make sense? That's why it's so important to go to a burn center. Okay, now we're understanding. You see? Okay, beautiful. Now, I have an example for you, folks. Come on, you know I got you. Okay, so here's our example Parkland formula. Here's our total body surface area at 23%. The weight is 100 keys. We do 4 times 23 times 100. We get 9,200 mLs. So now I got to break this up into what? 50% in the first 8, another 25% in the second 8, and 25% in the third. So all I got to do, take my 9,200 mLs, give me a chop 50%. You're in the first 8, second 8, you get another 25% chunk, third 8, and then another 25% chunk. Done. How cool is that? Okay, here we go. There it is. Is that pretty cool? Pretty cool? All right, I love it. Now, there is here also, you may have heard, the rule of 10. Let's break it down, okay? Rule of 10. We calculate the total burn surface area to the nearest 10%. So, multiple TBSAs by 10 to determine the fluid rates. For a patient, between 40 and 80 keys, they're over 80 keys, we add 100 mLs an hour for every 10 key. Now, for me personally, I think the first system of our Parkland system, it's a little easier to remember, but I do want to just share this with you here. Okay, so here's our example. We have 23%. Closest 10% would be rounded to 20%. Weight, 100 keys. 20% times 10, 200 mLs an hour. Add 100 mLs an hour per 10 keys over 80. It's a little nuanced here. 20 keys over, so we add 200 mLs an hour. 200 mLs an hour plus 200 mLs an hour is 400 mLs an hour. Okay, well, it works, but again, same. I think this is more nuanced with this. The other one is just cut and dry. Boom, boom, boom. We chop 50, chop 25, chop 25. We got everything we need. See ya. Okay. Hey, let me know in the comments which one you like better. But I gotta share all of them with you because we passed that test. Let's go. Okay. We folks are moving on to medical, and in medical, again, each of these sections I sat down, I said, what is the most high yield content that I can deliver to you? And what are the emails and messages that I always get asked about that people, God, I had a question on DKA and I got the physiology, the pathophysiology, right? This is why we're going over some of this stuff. You ready for DKA? Let's go. Okay, now, you probably heard about this, and be honest with me in the comments. Did you hear about HHS in paramedic school, and you still have no idea what it is? I know it. That's why I'm here to teach you. So let me show you. Diabetic ketoacidosis versus hyperosmolar, hyperglycemic state. Now, the first thing I can tell you is this. Type 1 diabetics get DKA. HHS is usually more of a diabetes type 2 thing. Okay? Well, I'm going to walk you through it, but I'm giving you a little preview. Now, look. They're both life-threatening diabetic emergencies. They both involve extremely high blood glucose. They're caused by problems with insulin, and paramedics must recognize the difference. So imagine you get a scenario of a diabetic on the National Registry Paramedic exam, and you think it was DKA the whole time, and then this was the actual, it was actually HHS, and you were doing everything wrong, right? That's why we're not going to have that, okay? So let me first want to understand, people, give me the physiology. Let's start with that. We need to be a master of diabetic emergencies as a paramedic. So let's talk about this. What insulin normally does, and when we don't have insulin in the body. Okay, think about this as a lecture you never had. Okay, I'm going to give it to you now, right? Now, what insulin normally does, it normally moves glucose from the blood into the cells. It allows the cells to use glucose for energy. Okay, so insulin is the key that unlocks the way for glucose to enter the cell, how we get energy. Okay, if my insulin key isn't working, or I don't have insulin, glucose is going to hang out in the bloodstream and go, where do I go? And when we get a finger stick, we check the blood glucose, it's high because it's all in the blood. It's not going in the cell, right? So it stops the body from breaking down fat for fuel, okay? And it helps maintain normal blood sugar levels. Without insulin, glucose stays in the bloodstream, and cells cannot use glucose for energy. And they don't like that, okay? So we'll explain what happens, okay? Here we go. What happens without insulin? When the body cannot use insulin, the cells think they are starving, okay? The body begins to break down fat for energy. Fat breakdown produces ketones, and ketones are acidic. This leads to a metabolic acidosis. Wow, doesn't this sound like something we talked about earlier? It sure is, folks. It's called DKA. Okay, now here we go. You're gonna love this. Here's what happens without insulin. Picture this. Your body is a car. The cells are the car. The glucose is the gasoline. The insulin is the key. Okay? Without insulin, the key cannot start the car. The car cannot use the gasoline. The body starts burning fat for energy instead. Burning fat makes ketones, and that prolonged buildup of ketones leads to a metabolic acidosis, which is a diabetic ketoacidosis. Okay? Does this make sense? Smash that like button and let me know in the comments if you love this slide. This one's one of my favorites. Let me know which one was your favorite. With diabetic ketoacidosis, it's an absolute insulin deficiency. So remember, type 1 diabetics have a problem with, they literally don't produce insulin. Type 2 diabetics, they have an insulin problem that has gone on over the years, okay? Rather insulin resistance, right? Like their locks aren't working. Some work and some don't. They got tired locks. Whereby type 1, they don't produce any insulin. They need to get insulin injected into them to have any insulin. Where diabetic type 2 is, their insulin is kind of, it's not as good as it used to be, if that makes sense, okay? And we'll talk more about it, but just hang with me. It's an absolute insulin deficiency. It's most commonly caused by type 1 diabetes. Pathophysiology, okay? There's no insulin available. This is why type 1 diabetics require insulin, okay? Fat is broken down for energy, ketones are produced, and a metabolic acidosis develops. And here are clear-cut signs and symptoms of DKA. Glucose levels about 250 to 600. What are you talking about? Up. Kussmaul respirations, which we know is a compensatory mechanism, okay, that the body will use to correct the acidosis. You learned it earlier, okay? It helps release excess CO2, which is acidic, because we learned about it earlier. We know CO2 is an acid, so that Kussmaul breathing that we see, that rapid, deep breathing that we see, Kussmaul breathing, is a compensatory mechanism in this case, okay? Because the patient is acidic. And that fruity breath, that fruity odor in their breath, abdominal pain, nausea, vomiting, severe dehydration, and they're probably confusing altered mental if they're calling 911. Now, the difference when we talk about HHS It is not an absolute, it's a relative insulin deficiency, most common in type 2 diabetics. So folks, think about it. If I look at a med list, I'll go to med list. I see someone's taking injectable insulin. More than likely, they're type 1. If someone's on metformin, for example, and they're only on diabetic pills, they're probably type 2. Why? Because type 1, they need insulin from outside source. They don't produce any. If I'm just taking, a diabetes pill, right? Well, of course you're type 2 because you wouldn't last very long with no insulin. You have to have something going on, right? So one is a broken insulin glucose system, and one doesn't have any insulin, and it's been like that since they were a kid. Okay? Okay. Key features. Extremely high glucose, 6 to 1,000. Basically, it's going to read HI high on your glucometer. Severe dehydration. Now, in HHS, there is still a little insulin, so fat is not burnt. But the sugar becomes extremely high and causes severe dehydration. There's minimal to no ketones and minimal to no acidosis. So we can see a difference here. What is the big difference between these two? Look here, folks. The Kussmaul respirations, the ketones, okay? And this, they're both high. They're both going to be high. But, maybe in blood work we can see it's a little higher, okay? But the biggest difference really is the ketones and the Kussmaul. And why we get the Kussmaul in the first place. But wait, why doesn't that get Kussmaul? Because they're not in a diabetic ketoacidosis. This is a compensation mechanism. That's why we don't have DK, those Kussmaul respirations with this one. Does that make sense? Okay. So what this means, which is why Kussmaul respirations is your hallmark sign symptom of DKA because it's the only one that has it. Rapid and deep. Make sense? Okay, good. Now let's talk about ALS treatment. So the major threats for these patients, severe dehydration, electrolyte imbalance, altered mental status, and shock. The paramedic priorities. We have airway management. So if we look at Kussmaul respirations are not respiratory failures. This is a big thing. Kussmaul respirations, they may look like they're in respiratory failure, but they have a diabetic problem. They are in the respirations are a compensatory mechanism in the metabolic acidosis. We never want to suppress the compensatory respirations, underline this one. We never want to suppress the compensatory respirations unless the patient is unable to ventilate. Now, oxygen if needed, IV access, fluid resus, and a rapid transport, and there it is. Now, with that being said, I want to touch on a subject that's overlooked a lot in paramedic school, potassium-related emergencies. So we understand how this works. So let's talk. Potassium, folks, as we know, is critical for the cardiac electrical activity, that's heart rate and conduction of the heart, muscle contraction, and nerve transmission. Small potassium changes can cause cardiac instability and or fatal arrhythmias. So our normal potassium level, remember this, is 3.5 to 5, okay? Now, hyperkalemia, hyper, too much, hyperkalemia, high potassium. Common causes. Your dialysis patient that you might have on your National Registry Paramedic exam. Remember that, okay? Common causes. Renal failure, dialysis patients, crush injuries, metabolic acidosis, certain medications. Now, folks, hyperkalemia causes an increased risk of severe cardiac arrhythmias. Hang with me. There's a process With the EKG changes, as the potassium gets higher, the EKG changes, okay? So, I'm gonna give you a little preview, we'll do one of our little acts here, acting out, okay? Here it is. I have high potassium, okay? What's gonna happen? The first thing, I get a tall T wave. I get a tall T wave. Then, hey, I'm the QRS, I wanna join in. Now I get a wide QRS. I get a wide QRS. Okay, now I'm doing something funky. Why? Oh, I'm a funky sine wave. You end up getting a funky sine wave, right? So we start with a tall T, we get a tall T, we get a wide QRS, Now I'm doing something funky. We get a wide, funky looking sine wave. I'm gonna show you, okay? Ready? You enjoy that? All right, pretty cool. I will do anything in my power for you to pass your exam, okay? The paramedic coach is obsessed with one thing. You pass that exam. Now smash that like button, let's go. Okay, here we go. Potassium level EKG changes. 5.5 to 6.5, and when we draw blood, here we go. We get a tall peak T wave. A T wave that we don't want to be anywhere near. It looks like a spike, okay? 6.5 to 7, the P wave is wide and flat, okay? It eventually disappears, and we get a prolonged PRI, okay? Now, here's where we get into the real meat and potatoes. 7 and 9, we get a wide QRS, tall peak T, widening QRS, funky sine wave. Okay, you're never gonna forget it now, right? I know. No, this is a clinical note I wrote for this. Okay, here I'm gonna read it out to you. The progression of the EKG changes is the same in every patient, but it may not correlate with the potassium levels listed above with every patient. For example, patient A can have a sine wave at a potassium level of 7, while patient B displays a peak T wave. So by the textbook definition, this is what is supposed to happen. As they go up, they go from here to here, okay? Now in the field, do we really care whether it's a sine wave or a tall peak T? Well, a little bit, but here's why. We see a sine wave as the absolute worst wave on here and the highest level of potassium. If we see a sine wave, we know they're really, really sick. Now, they're going to be sick anywhere along this course, but we can see it getting worse before our eyes on EKG, or maybe it's getting better in front of our eyes on EKG. So what do I always say? Keep burning, keep printing EKGs. You will see things change in front of your eyes for good or worse. Cool? I love it. Okay. Now, you know I got pictures, folks. You know I got pictures. All right, now here we go. You know, hyperkalemia. Check me out here. We have a tall T wave. Look at that T wave. T wave is supposed to be all the way down here. Like this tall. Look how tall that is. It's trying to compete with the QRS. Tall T wave. Prolonged PRI. Look at that PRI getting longer. Okay? Now, look at the wide QRS with that tall T wave. And now look at that funky sine wave. Because it kind of is like this, right? Funky sine wave, right? Okay? Tall T, prolonged PRI, wide QRS, funky sine wave. Pretty cool? All right, I love it. Now, what are signs and symptoms? Well, weakness, muscle fatigue, okay? We can have nausea, bradycardia, dysrhythmias, okay? Of course, we're going to continue to reassess the patients, okay? Now, these are vague symptoms. Folks, this is why, you know, in hospital, we get blood work, right? A doctor or medic, whatever, any medical professional can look at a patient we need some information. It's great to get chief complaints. It's great to get a history. But this is why I draw blood work. And you can see, right? It's why we do an EKG. But isn't it amazing that you could pick up hyperkalemia from your life pack, your Zoll monitor? I think that's pretty cool. Okay? Now, we got something different now. Now we'll move on to a new topic. What about hypokalemia? When potassium is too low, completely different. In this case, I don't have enough potassium. Vomiting, diarrhea, diuretic use. Now, what? Hang on, let's pause. Why would overuse of diuretics cause low potassium? Well, a diuretic's job is to, obviously, what's the job of that? Remove fluids. So, if we have a diuretic that brings potassium along with it as we're flushing fluids out of our body, that could be it. Okay? Poor nutrition, prolonged illness. Hypokalemia causes an increased risk of ventricular arrhythmias. Now, there are EKG changes with hypokalemia. Flattened T waves, ST depression. Whoa, prominent U waves. Check me out. I'm going to walk over there and show you. Ventricular ectopy and the risk of torsade points. This is very interesting. Now look here, folks. Hypokalemia, okay? Now I'm going to roll over here. We'll come back here, don't worry. Look here, we can see here's our isoelectric, okay? My P, my QRS complex, okay? Look here at my ST segment. There's my beginning of my T wave. Okay, look at the ST segment here. Is it up, down, or okay? There's isoelectric. It's all the way down here. Okay, so there's a little bit of ST depression that we can see there. Okay, a little bit. Okay, not a lot, but a little bit. And now look over here. We can see here that U wave. The U wave comes, is your T wave, after the T wave. It's a U wave. And that a U wave has to do with hypokalemia. Okay? Now, high-risk patients. Dialysis. Why dialysis? Because in dialysis, we're moving blood. We're moving fluids. We're moving electrolytes. Okay? We're shifting things in the body. Okay? Patients that either haven't been to dialysis or post-dialysis, that's a tricky time, okay? Or we may get called to a dialysis center, someone's home, etc., etc. We're going to see these changes, okay? So remember that in your cases for a national registry. When we suspect potassium abnormalities, dialysis, renal failure, again, severe dehydration, crush injury patients, patients with prolonged illness, remember, potassium abnormalities affect cardiac conduction. Recognize these patterns to help prevent cardiac arrest. So now we know what these EKGs look like. If I see a U wave, they're low in potassium. If I see my tall T, wide QRS, funky sine wave, I got hyperkalemia. And it's all because I know cardiology. How cool is that? Well, that's you now because you're about to be a medic, right? Folks, we're moving on to EMS operations. You ready? Let's get after it. Now, quick note before we start. In that free study guide, I mentioned a little bonus for you. In that free study guide down below, not only do you get all the content that we talked about and all the information we talked about in this video in a free study guide, you also get access to a free quiz with that study guide as well. And in that quiz, you're going to get free clinical judgment style questions written by me, and they're in there for you inside your free study guide. My little gift to you for hanging out with me here on YouTube. All I ask, smash that like button, hit subscribe, and introduce yourself to me down below. Tell me what you're working on. Ask me a question, comment. I'm here to help. And tell a friend about the Paramedic Coach. Pretty cool? All right, let's go. Let's get after it. So, triage, primary triage and secondary triage. Here we go. Now, triage is the act of categorizing patients at a mass casualty incident. So, you always think about a train, a bus, a plane. This is good because they are all MCI events, So we think about that. Now, primary triage, folks, is done, remember, in the field. Secondary triage performed in the treatment area. Someone that is tagged primary out in the field, it may get changed in secondary, okay? So this is very important. Now, the most common triage system that we look at is the START triage system, and we're going to talk about in a moment, okay? And it's all from color-coded tags, okay? So START triage, it is one of the easiest for adult patients. Remember that. Jumpstart triage, different, is for pediatric, okay? Adult is START triage, okay? And it breaks down really, if you remember one thing from this section is their ability to walk, their respiratory status, their hemodynamic status, and their neurological status. So basically, we get to an MCI, okay? Get out our imaginary air horn. Hello, if you can hear me, walk to XYZ place now. They go, start moving over, okay? The people that can walk and do that are the walking wounded. If the people that are there in the field or in the scene, if you will, those patients are not ambulatory. So the question is, what are we going to tag them? Black, red, yellow, what, right? The green will be the walking wounded. Now what can happen is, just because somebody can walk and be green, doesn't mean that they're not hurt and injured and sick. So we're going to talk about that later on. So just remember that little pearl, okay? But if you look at this, the ability to walk is first, and then is the respiratory status. Is it like, are they breathing? Is their airway open? If I open the airway, are they breathing? Right? Hemodynamic status, get a pulse, check cap refill, and then neurological status of the patient, right? Can they obey commands? Are they awake? Right? That's what we're doing. And then you keep doing that patient to patient and tagging the patient. That's the process of triage. And I'm going to walk you through all of it step by step. Okay? But that is the assessment. Okay? Now, here we have all of the tags. So basically, the first step is, remember folks, is walking wounded. This is our green priority. These are ambulatory people. Maybe they have minor fractures or minor soft tissue. Folks, this is important to remember. If I go to a patient at an MCI, and that patient does not have a pain airway, their airway is not open, and they're unresponsive, and I go open their airway, and they're not breathing, I'm tagging that patient black, okay? If I open the airway and now they're breathing, well, now they're red. Or if I get to them and their breathing's not so good, really, really slow, really, really fast, again, they're not tagged black, they're breathing, but they're probably going to be in the red, okay? Yellow, they're going to pass all these checks that we're going to do, which I'm going to show you at the end, and they're basically in a delayed state. And then this orange tag here is what we talked about. They're ambulatory, but yeah, they're able to walk, but why can't they have an injury? Just because they're able to walk. I've seen plenty of injured patients after a motor vehicle accident that hop right out of their car, right? And then all of a sudden they're like, oh, I don't feel so good. And they got chest pain because it's the adrenaline. And that can happen with it's orange tag, okay? It's intermediate tag. So I'm gonna run you through all this, but this is important to know that red tag is immediate first priority. Yellow is delayed second priority. Green is third priority, walking wounded. Black is a fourth priority. And in some areas, they have a new orange tag, where the orange tag is intermediate between red and yellow, actually. Okay? So this is pretty important to know. The black tagged patients are not going to be transported, likely, because you're at an MCI. So the big key here to remember, folks, if you ever get a question about ethics on the exam, is remember this. Normally in EMS, we're supposed to do the most good for that one patient that we have, and we do that. unfortunately, at a MCI event, we need to make decisions based upon, we need to save the most amount of people possible. So this is what this system does. It allows us to save the most amount of people possible. Does that make sense? And put our resources to the most needed. Does that make sense? Now it can sound cold, but it's true. And you should understand that getting into EMS. I understand you're about to be a paramedic. I get it. But just to be clear. Make sense? Okay, good. Now, first step. Call to your patients. Can you hear my voice? Can you walk? Pick a location away from the ambulance so we don't have mixing of patients. And we tag them green. Now, this is where we get into step 2. Step 2, we assess the patient who's non-ambulatory. We walk up. Is the patient breathing? If they're not breathing, open the airway. If they're not breathing, tag black. Begins to breathe, tag red, recovery position on your side. If you walk up and they are breathing, assess the respiratory rate. Really slow, really fast, tag red. Fine, you can do recovery position too, no problem. If they're between 10 and 29 breaths a minute, they move on. You might be yellow, okay? Now we're going to assess hemodynamics, pulse and cap refill. If there's no pulses, there's no cap refill, whoops, you're red. If there is, oh, I'm sorry, not no cap refill, excuse me. I'm going to redo this. Ready? 3, 2, 1. So, you just might be yellow if you give a chance to move on to excess hemodynamic status. Let's see. If we get a radial pulse and we check cap refill and it's over 2 seconds and there's no pulse in the radial and the cap refill is over 2 seconds, your blood pressure is likely not very good. That's tag red. If you have no radial pulse and your cap refill is under 2 seconds, we move on to the next step. If your radial pulse is present, we just move on to the next step. If you have an ability to understand and follow commands, then you're actually going to be tagged yellow. And if you're unable to follow commands or unconscious, you're tagged red. So what does this mean when we look at this? Well, in summary of this slide, if you are tagged black, you are look at, folks, look at the chart. If you're tagged black, you're unresponsive and you're not breathing, even when we open your airway. So you're tagged black. Likely you're in respiratory cardiac arrest. Well, you are. Okay? Red, you're breathing. You probably don't have a radial pulse, as you can see. Okay? I mean, look, you see here, they weren't breathing initially until you open the airway, right? They probably don't have a radial pulse, and they're probably confused or unconscious. Where the yellow tag can't, this is a big differentiator. The yellow tag can follow commands. The yellow tag has a pulse, or at least has a good cap refill, and is breathing between 10 and 29. See the difference? That's why we do the tag system. So we do the most good for the most people. Exactly. There it is. Okay. Now, this looks crazy, but it's really not that crazy. I'm going to break it down for you right now. Check it out. This is why I love start triage, because it's very simple. I look at your airway, I look at your pulse, I look at your cap refill, how is your mental status, and I move on. It's easy to remember, right? So we go up. The ambulatory is the walking wounded. You're green. Maybe you're going to be an orange. We'll figure that out. But I'm going person to person. Here I go. Respirations. Are you breathing? No. Open the airway. Are you breathing? No. Black. Are you breathing? No. Open the airway. Oh, now you're breathing. Recovery. Red. Okay. Are you breathing? Yep. 10 to 29. Move on to the next step. Are you breathing too slow, too fast? Red. Right? Does See? Now move on. Radial pulse present, or is the radial pulse absent? If the radial pulse is absent, we check under 2, over 2, over 2, control bleeding, and tag red. If we have the radial pulse present, check out refill. Under 2 seconds, move on to mental status. If we got a pulse, radial, assess mental status. Move on. Can they follow commands? The yellow. Can they follow commands? Can they not follow commands? Red. So folks, pretty simply, you're not going to make the cut to be a yellow if you're breathing way too slow or way too fast, if you have bad cap refill or dull radial pulse, or you're confused or can't obey commands, you're not going to be yellow. That's the takeaway. And remember, the black tag, important. You walk up, not breathing, open the airway, not breathing, black next. See how fast it can be? So like we see, as we're going through, because there's so many patients, this is why the system is set up like this, so it's like quick. Like I really don't want to get down to yellow. I just want to keep tagging. This is why it's so fast, right? I want to get down to yellow, of course, because the patient is going to be in a better state. But as far as tagging the most people, these red people need to be identified quick. And that's why they had a system. Make sense? Beautiful work. Beautiful work. Guess what? We did it. You watched the entire video. You are now ready to go crush that National Registry Paramedic exam. I'm really proud of you. You sit here, watch the video. Now here's the good news. This video is here on YouTube. You can go back and replay it. I want you to listen to this video when you're in the car, you're driving around, you're doing chores. Watch this video over and over and over again. Smash that like button, hit subscribe. And by the way, if you want to take things to the next level and you really want to get your studying going for National Registry, our flagship program has been used by over 60,000 EMS students all over the nation. This program includes over 480 videos, worksheets, practice questions. It's down in the link in the description. And don't forget to grab your free study guide from this video. It goes over all this material so you have it, quizzes, and you get access to those free clinical judgment questions. So make sure to grab that. It's all down in the description. It's all there for you. Like, subscribe, and I'll see you on our next education video. Watch this over 3, 4, 5 times and go crush that exam. And do me a favor, tell me in the comments when you become a brand new paramedic. Let's go. I cannot wait to see your success. And I'll see you soon out there. Be wearing this hat like me. Let's get it.